So, a very good morning, everyone. Today, we're gonna learn how to take perfect history and examination for obstructive jaundice for the general surgery. In the general surgery, I'll be making 3 videos regarding abdomen. One would be obstructive jaundice, one would be your appendicitis, and third one would be your right iliac fossa mass. And then I'll try to make abdomen examination video for your medicine. So that's how we will cover your abdomen examination in general surgery and medicine. So this video, we will also try to cover your pancreatitis and liver secondaries. So let's start. So basically when we say obstructive jaundice, so definitely the first symptom is obstructive jaundice. And then to differentiate it from a medical jaundice or from a obstructive jaundice. Obstructive jaundice is a specialty more of a surgery where there is an obstruction, and general surgery or your gastric surgery will do some operation to remove that obstruction or something. So it will have a classical feature where your direct bilirubin is increased, which will cause itching, high color of urine, pale color of your stool. So basically, you need to understand there will be jaundice will be the first symptom, second would be itching, third would be a high color of urine, and fourth. If all these symptoms are there, then you can label this patient as this patient has obstructive jaundice. And what are the common causes? So here is one of the mnemonic, which you can easily see, which is COIN, C for congenital related, O for obstruction of the common bile duct, which could be due to stones, biliary structure, parasitic infestation, inflammation, extrinsic compression, and neoplasm. So in this video, we'll be mainly focusing on carcinoma of head of pancreas or periampullary carcinoma and your cholecystitis. So these are the major and common causes of obstructive jaundice, and we will be mainly focusing on these. And also, as I already told, we'll also cover pancreatitis. And now we'll move toward the history taking. So definitely we'll ask name for identification, then age. Generally what happens as the age increases, your chances of gallbladder stone increases. Why? Because the cholesterol level increases in the body. There is decreased bile pool, and there is decreased gallbladder motility. So what happens? All these factors will result into formation of your gallbladder stone. One is that. And also, like with the age, if you see chronic pancreatitis is also common in the age group of 40 to 60. And then we move on to gender. In gender, females have higher probability of getting gallstones. Like you would have already heard about something like female, fat, fertile, and 50. So this is one of the indication which says, okay, the patient might have a chronic cholecystitis. This is the typical profile of the patient. So occupation, education, hailing from, this all are the common details you have to ask. Then moving on the chief complaint for what the patient has come to you. So it could be most commonly would be yellowish discoloration of the eyes for this duration, or it could be high color of urine, pale color of stool, or clay color of stools. It could be itching, it could be fever, it could be vomiting. These are the common chief complaints for which patients come. Fever, we see in the case of cholangitis, or there is imagine if there is any obstruction of the bile duct, then there will be stasis of your bile, and there could be secondary infection, so which can cause your cholangitis. Then history of presenting illness. As usual, we'll say patient was apparently well this many days back when he or she noticed yellowish discoloration, like definitely in the mirror. Or else what happens, generally with the jaundice, uh, someone else, your neighbor, friend, or someone will tell, oh, you have a yellowish discoloration of the eyes. So then they will start noticing the system, and then they may land up to the hospital and regarding their problem. So that thing you have to make sure, and rest others you can mention. If jaundice was the first symptom for which he has come, then you elaborate jaundice. If it was a pain, then you start. If it is fever, so depending on that, you start. So basically, mostly it would be jaundice. You have to see when did it start, what is its duration, was any prodromal symptoms, like what happens in case of viral hepatitis. Fever could be before, and then jaundice may appear some days later. So that will give an indication that this is a viral hepatitis case. If the patient has pruritus, means itching, then when did it start, what's the duration, is it progressive or not? Because his pruritus is increasing, his jaundice is increasing, seems like his bile stasis is also increasing, means the disease is also increasing. Is there a clay colored stool or not? Whether the progression is gradual or intermittent? Will deal with this. Like for example, when there is a waxing and waning of the jaundice with black tarry stool, so this give an indication of melena. This gives waxing and waning. So what happens? There is intermittent jaundice. This is periampullary carcinoma. In the next slide, I'll tell you how to differentiate periampullary carcinoma. What is periampullary carcinoma? And this is your whether it is associated with pain or not. So we'll see in the next slide what is painful jaundice, what is not painful jaundice. Just one point here. In case of inflammatory bowel disease, in case of inflammatory bowel disease, you will have jaundice, you will have arthritis, means the patient will have, and the disturbed bowel and bladder. Disturbed bowel and bladder habit will be there. So that can give you an idea about maybe it's a Crohn's or ulcerative colitis. So if it is a painless, there is no pain, but the patient has jaundice, and you are suspecting obstructive jaundice, then you have to see whether it is continuous and progressive. If it is continuous, persistent jaundice and progressive in nature, then you have to suspect of carcinoma of pancreas. If it is intermittent, waxing and waning, I told. So there is carcinoma of periampullary. So what happens? What is periampullary carcinoma? Periampullary carcinoma, like here, for example, it's your pancreas. So it's a 2 centimeter area around the ampulla. Around the ampulla. So you have this 2 centimeter of area. That is what you will call as periampullary carcinoma. And what happens? Why there is waxing and waning of the jaundice? So some part of this, I'll change the color. So some part of this carcinoma will slow off or will break and come out. So that slugging will cause bleeding and melena. That's why waxing and waning with the black tarry stool will give you a idea that it's mainly periampullary carcinoma. And then when we talk about periampullary carcinoma, just a minute, you can remember the mnemonic is PACD. So most common cause of periampullary carcinoma is head and neck cancer of the pancreas. Then is your ampulla. Then is of your distal cholangiocarcinoma. Then is of your duodenal carcinoma. So this is what you have to remember. Most common is pancreas, then ampulla, then cholangiocarcinoma, then your duodenal carcinoma. And it presents with jaundice early. It's a good prognosis because the patient reaches to you early. In pancreatic carcinoma, mostly it is the head of the pancreas, which is more prone for cancers, will present only with the weight loss, may not present with much more other symptoms. Like in the next slide, I'll tell you how to differentiate between the carcinoma of head of pancreas and the body of the tail of the pancreas. And it will have a poor prognosis because the patient comes late. Whenever you see painful, like there is a pain with jaundice, always suspect your stone of the common bile duct. And it typically has your Charcot's triad. And what encompasses of Charcot's triad is fever, intermittent fever with rigor, because it's due to the obstruction and the infection. There is jaundice, obstructive jaundice. There is pain. Pain is due to the blockage of common bile duct and due to the spasm. It's kind of more of a colicky pain or a biliary pain. And second reason would be a common bile duct stricture formation. So next slide is here where you have to differentiate between carcinoma of pancreas and body and tail. More, as I already told, head of the pancreas is more prone for the carcinoma of pancreas. Mostly it will be painless, but in the later stage, it might be painful, and then the patient comes with the might come as first symptom as pain, but very less. Mostly jaundice will be there, which will be progress deepening, and it will have a palpable gallbladder due to this. We will talk about this Courvoisier's law in the upcoming slides. Then less chances of body and tail to have carcinoma, but they typically present with the pain of pancreatitis. Like, it's a very typical pain. It's very severe, intolerable type of pain which radiates to the back. At the back, uh, it's the reason of L1 and L2. There is a retrosternal inflammation, and the pain will aggravate when the patient lies down, and pain will relieve when the patient sits up or stoops down. That will reduce the pain. Regarding the jaundice will occur in very less of the cases, less than 20% of the cases. It might be present in case of there is a liver metastasis. So, and definitely the patient is coming late because because it manifests late, and the pain could be also due to the pain in the body and tail of the pancreas carcinoma. Pain could be due to also to the compression of perineural and splanchnic neurons and the adjacent organs. So that takes time to compress on the other organ or other neural plexus. So that's why the patient comes late to us, and definitely there's a poor prognosis. And if there is a carcinoma, definitely they will have common symptoms like anorexia, nausea, weight loss, and steatorrhea as a symptom of malabsorption. We'll be dealing with this in detail in the next few slides. Then there is could be thrombophlebitis migrans, which is we call as sign, which is also seen in GI malignancy, also seen in your Burgess disease, and more specific in the GI malignancy, it is seen in pancreatic cancer. I'll tell you in the general exam, in the inspection, in the general examination of this video, how to see for your Trousseau sign and what it is in detail. After this, you have to look for the history of pain. Which side is the pain? It's epigastric, or is it your hypochondriac, right hypochondrium pain, left hypochondrium pain? Decide the parts. As you already know, abdomen is divided into 9 parts. Hope everyone is well versed with it. And then what are the differential diagnosis of this pain and all? I'll be dealing in the video of right iliac fossa mass. What is the nature of the pain? If it is dull aching, could be cholecystitis, gallbladder related. Stabbing, severe, intolerable pain could be due to pancreatitis. Biliary colic, gripping type of pain could be due to the bile duct or your biliary. Whether the pain radiates or not. What happens is in human body, pain related to anything related to gallbladder might go toward the right shoulder. Pain, anything related to a spleen may radiate to the left shoulder. So, and for the aggravating factors, if it is due to fatty food, generally in cholelithiasis, there is a qualitative dyspepsia. What happens in case of cholecystitis pain? Like, there is a gallbladder and there is a stone. So what happens is pain will be felt on the outer border of the right rectus muscle. So let me show you. Imagine, pardon me for my bad drawing. So this is the midline, and this is his left costal, and this would be somewhere would be rectus. So the outer border of the right rectus muscle, and just below the costal margin, here is your GB point, and that would be the pain where it will be paining a lot for the gallbladder stone or gallbladder related pain, and it will go to the right shoulder and right inferior angle of the scapula or the right scapula. Suggestive of gallbladder disease. In the gallbladder related pain, like due to the stone or infection, it will not have much relation with the fluid, but some people might complain of pain with the fatty meals. Pain will be free of intervals, like it will come in once in a month or a few duration and then keep on coming with certain duration. There will be some interval. Now, I have already told if there is no pain, if it is a painless jaundice, then It could be due to your pancreatic carcinoma or your periampullary carcinoma. In case of pancreatitis pain, it'd be a boring type of pain, biliary colic at the epigastric site and radiates to the back of the retroperitoneal inflammation. I already told it be intolerable, relieves with sitting up, and increases with eating. Sometimes patient is also even scared of food, and pain will last for 3-4 days, and vomiting will be present in almost 50% of the cases. Then you look at the fever. Fever, I already told it is part of your Charcot's triad. Due to the CBD stone, there might be infection, secondary infection, and then is your other history of presenting illness like postprandial belching. You can see where there is a feeling of fullness after food, there is belching, there is heartburn. Flatulent dyspepsia could be there in the gallbladder related disease, and you have to look for the history of nausea, vomiting, and steatorrhea. Steatorrhea, I already told, it's bulk. How do you ask in the history? Because patient won't say I have steatorrhea because it's such a medical language and the jargon. So basically, you have to say how you have to ask is the stool fatty, pale, foul smelling, and when you flush it, does it tend to float? It denotes that there is a lot of fat in the stool, and there is a malabsorption. Malabsorption. So steatorrhea is a classical symptom of the malabsorption and can be related to pancreas because pancreas only secretes all the digestive enzymes. And then you have to think of pancreatic related disorders when there is a dysteria. This gallbladder disease will have history of flatulent, and there will be seen, it can be also seen this flatulent dyspepsia in case of esophageal hiatus hernia, and in case of your chronic pancreatitis also you will see this flatulent dyspepsia. In generally with the gallbladder disease, patient will dislike the food. There will be flatulent dyspepsia. Nausea is very common. Nausea is very common, but vomiting is less. And vomiting in case of pancreatitis will be profuse and projectile and follows the pain. So you have to remember, in case of pancreatitis, the vomiting will be profuse, it be of projectile, and it will follow by the pain. So we have to ask about the past history, whether it's diabetes, hypertension, chronic heart, coronary artery disease or ischemic heart disease, asthma, history of previous gallbladder surgery. Why do we ask about diabetes is because diabetes do predisposes a person for the GB stone and for the pancreatic carcinoma. And you have to ask about the previous gallbladder history, whether it is already removed. Then you don't have to think of, if a person has already gone cholecystectomy, then you don't have to put your mind, okay, maybe it's due to gallbladder or not. Then think maybe something else is there. And also previous gallbladder history might suggest there might be any strictures formation would have happened. They may be ask any whatever history was done, was there any complications for had or not. Then any similar episode in the past, because in the patient with a gallbladder stone, they will have the repeatedly similar thing keep on happening in the after frequent or after certain intervals. Talk about the bowel history, personal history in which already bowel constipation or anything, diarrhea, how is the bowel movement, color of the stool, it would be pale in case of obstructive jaundice, melena in case there is a GI bleed. Normal bowel movement, what you can say is around 3 times, like 3 times a week to 3 times a day. It's completely normal. And then in case of, I already told pale stool will be there in case of obstructive jaundice. It could be of generally it is seen with the patient with ampullary carcinoma or pancreatic carcinoma. They might have a silvery stool like a aluminium foil color. Mucus, whether in the bowel there is a mucus or blood in the stool. If there is any blood or mucus, suspect of any colonic related or rectal related diseases. That thing you have to remember. So bowel will give you a bowel history will give you a good history about your GI. Constipation, if the person says the patient has constipated, then you can see whether it is due to the lesion in obstruction in the any GI tract will cause constipation. It could be there also in the gallbladder disease, chronic appendicitis, or melena. So I already with the melena, you have to remember it is seen mainly in the upper GI bleed. Then look at the significant weight loss you have to ask, because it will give you a hint toward any malignancy, because if there is any malignancy, there will be significant weight loss. For weight loss, generally in Indian scenario, patient may not measure their weight and they say, I have lost this much kg of weight. So if the person is not able to tell, if he has a good history, okay, I lost 10 kg, 5 kg, he's giving Apraxide, that's good. But you can also ask whether there is any loosening of the ring, whether the clothes are getting too loose, whichever they were used to fit in. That will give her a good idea. Steatorrhea, I've already told you that you have to ask in the bowel history. Chronic alcoholism and tobacco. Alcoholism is a risk factor for your pancreatitis also. Alcohol and smoking both are. Alcohol and tobacco both are the risk factor for your pancreatitis, your pancreatic carcinoma. And CBD structure is very common in chronic alcoholics, whether there is patient is taking any drug which is causing any hepatotoxicity, like in case of a TB medications, if they're taking, so the patient might have a jaundice due to the hepatotoxicity, whether they're any allergic to any drug or not. Then ask the family history, any congenital anomaly or not. Summary of the history, like this you can present like this year-old patient from this presented with the jaundice for this many days, as associated with clay colored stool, high color urine and itching, no history of fever or pain. There is no any significant history. It suggestive of obstructive jaundice. And then your examiner might ask, okay, what else could be the differential diagnosis, or what else you are thinking of? If there is anything else significant, you can just add it on to it. So then moving on to the next part, which is very important, which is examination. In the examination, if mostly we will start with patient is comfortable at rest, conscious, cooperative, oriented to time, place, and person. Whenever we say about build, it's mostly on the skeletal parameters. And when we talk about the nourishment, it's based on the BMI, whether it's average, poor, or you can say the BMI classification, whether based on BMI, patient is undernourished, moderately nourished, or is it patient is overweight or obese. Look for any scratch marks where on the chest or abdomen. This will give you a confirmation that pruritus is present. And look for any signs of dehydration. For that, you look at if there is any sunken eyes, there is dehydration of tongue and oral mucosa. Generally, why this pruritus happens is due to the accumulation of the bile salt in blood. Your GB stone patient will be generally obese, undernourished. There will be a cachexic look in case of patient with carcinomas. So now it's time to explain trousseau-sign. So what happens? What is trousseau-sign? So trousseau-sign is a blood clot and related inflammation affecting one vein or the group of veins, and then it migrates from one place to another vein. So that's why it's called as migratory. Seen in most of the GI malignancy. I've already told Berger's disease is also most common cause for it is seen is in pancreatic carcinoma. And the most common site where you can look for it is the leg. it will be palpable, it will be tender, and it could be mostly a subcutaneous nodule. Then you definitely have to look for pallor. If any, it could be, it's a pallor is a examination finding of anemia, which could be due to your malignancy or any GI bleeding. But remember, don't comment if there is a jaundice. If jaundice is present, then you may not be able to look at for the anemia, because whole body is jaundiced and there is a deposition of bile, and you may not be able to appreciate pallor. So you can say anemia, pallor was not well appreciated because of the jaundice. And where do you look for the jaundice or icterus, what we call as examination findings? So it could be, you can look at the sclera, skin, nail bed, under the tongue, and the soft palate. And for this, you have to remember that you have to examine for the jaundice in natural daylight. You cannot prefer not to see in the dark room with a tube light on or something. Prefer to examine for the icterus and jaundice in the natural daylight. That will give you about the jaundice. Cyanosis, if there's a lung mets, that time you can have or clubbing, lymphadenopathy, or pedal edema. You have to examine, then look at the BP, pulse rate, dyspnea, high respiratory rate. There will be a dyspnea in case of pleural effusion due to the lung mets. Look at the temperature if the patient has febrile or afebrile. Look at the SpO2. Now another symptom. Now moving on to the examination. Examination in abdomen is very, very important, and especially your inspection. Most important is your inspection. Because gallbladder related mass or swelling will be seen better than palpation. This you have to remember. And sometime, gallbladder might be even seen even in case of a thin patient. So it is seen better, you have to remember. Your inspection has to be very important. Look, before the abdomen examination, you have to take the consent. Make sure you take the consent. And whenever you examine abdomen, you have to examine all the 9 quadrants I already told. Look at the perineum, look at the supraclavicular fossa and renal angle. Do not forget that. Comment on the shape, whether the abdomen moves with the respiration or not. Any visible epigastric swelling. Comment about the umbilicus, whether it is midline or distended. Comment on the scar or vein. Look for the hernial orifice, renal angle, perineum, supraclavicular lymph node. Any fullness at the right hypochondrium could be due to gallbladder. Then, in case of the late feature of acute hemorrhagic pancreatitis or chronic pancreatitis, there will be distension, extensive destruction of the pancreas, and then you might see Cullen sign, which was described in 1918, and it is the superficial bruising of the subcutaneous fat around the umbilicus. It is seen in acute pancreatitis, seen also in case of your rectus sheet hematoma, seen in case of splenic rupture, in case of perforated ulcer, in case of intra-abdominal cancer or ruptured ectopic pregnancy. You can see because it's a complication of anticoagulation. This is your gray Turner sign, which is discoloration of the left flank. So discoloration of the left flank. What happens is refers to the ecchymosis of the flank and may occur in conjunction with the Cullen sign, especially seen with patient with retroperitoneal hemorrhages. So if this all you could find in the inspection, you can mention about it. Then moving on to the palpation part. In palpation, you have to make sure the patient is lying down straight. Okay, here is the head. You have to palpate with the finger pulp. You don't have to poke the patient. Don't poke the patient. Start with for the palpation. For palpating the liver, you have to start with the right iliac fossa, then move hand. You have to move the hand when patient exhales and try to palpate the liver when the patient inhales. So the liver border, you might touch your finger. Normally, liver will be palpable in children up to 3 years. It could be normally palpable. Spleen is not palpable normally, but when spleen is palpable, uh, it means spleen have enlarged at least 2 times. That's why you are able to palpate, and spleen will move freely with respiration. It has a sharp anterior border. When we see the abdomen examination, there I'll tell you how to differentiate between a splenic swelling and a renal or a kidney related swelling. Spleen will have splenic notch also. We'll discuss about spleen and liver examination in the medicine examination. Right now, we'll focus on our today's case, which will be related to the gallbladder. Just for the palpation, you have to look, you do a superficial palpation, you do a deep palpation. In the superficial, always look for the warmth and tenderness. This don't forget in surgery. It's very, very important. For the deep one, you palpate liver and your spleen and other organs. So basically, uh, at the back of your hand, you can just compare at the abdomen and the chest, see if there is any local warmth, because it's due to the inflammation, could be seen in the peritonitis also. If there is any tenderness, that you have to do a superficial examination. And if there is a tenderness and guarding just below at the tip of the ninth costal cartilage on the lateral margin of rectus, I have already told you this is your GB point. If this is a rectus muscle and this is the ninth costal cartilage. Palpate for the liver. If the liver is enlarged, it could be due to the bile stasis, METs, lymph node compression, compressing the portal veins. If the edge, comment on the edge of the liver. If it is sharp or rounded, smooth or irregular, nodular, consistency, soft, firm or stony hard. Look at the tenderness of the liver, whether it is present or not. So now, if the liver is stony hard and irregular surface is there, look for think of the metastatic deposit. If the liver is firm, irregular surface, and there's a small nodule, think of liver cirrhosis. If the liver is soft and tender, think of amoebic hepatitis. I will deal with these three, and also how to differentiate between liver mets and not. At the end of this, towards the end of this video, I'll be talking about that. In this, if there is any spleen enlargement, you can think if there is any malignancy which has gone toward the splenic vein invasion is there. Palpate hernial site. What I was talking about was the BOA sign on the back between the 9th and the 11th rib on the right side of the posteriorly. If you feel any hyperesthesia, for checking the hyperesthesia, you can just pinch the skin or try to pick up the skin. Then if there is acute hyperesthesia, if there is a hyperesthesia, then you can think it could be due to the cholecystitis. So coming toward a very important part, which is palpation of the gallbladder. Gallbladder would be, as I already told, would be seen better compared to the examination. And it will be palpated when it is distant. So we have to describe the swelling. Mostly it is a tense globular swelling, which is oval smooth swelling, and soft projecting downward, forward from below the liver, just lateral to the outer border of the rectus muscle below the ninth rib. And it will be intra-abdominal swelling. This all I'll tell you how to differentiate whether it's intra-abdominal or intraperitoneal. It will move, which moves freely with the respiration along with liver. Upper limit continues with the liver and can be moved from side to side. You have to remember, gallbladder is not ballotable like kidney. If the examiner say, what if it is the right kidney of the patient? Say it is not ballotable. Gallbladder is seen, palpable gallbladder, when we say it's distended. It's seen in case of your mucocele, empyema. In case of acute cholecystitis, it could be also palpated. When we say palpable gallbladder with obstructive jaundice, then think of carcinoma of pancreas, think of carcinoma of gallbladder, carcinoma of common bile duct. In case of carcinoma of bladder, it would be hard and irregular mass. Then moving on to the Murphy sign. Murphy sign seen in acute cholecystitis, not in chronic. In acute only you will find Murphy sign. In this patient is sitting. Place the right hand just below the right costal margin, lateral border of the right rectus. That's the gallbladder point, fundus of the gallbladder. Tell the patient to take a deep breath. And then look at the patient's face. If he winces, like, oh, it's paining, then it's an inflamed organ. Think that gallbladder is inflamed. So it is not seen in chronic cholecystitis, but in acute, and it is won't be also, you won't see it in uncomplicated cholecystitis. There is something similar to it that's called pseudo Murphy sign. What happens when a radiologist is doing ultrasound? He will keep his ultrasound probe over the gallbladder site. Patient will wince or will have a pain. So that's also called a pseudo Murphy sign. There is another method, Moynihan's method. In similar like where Murphy sign, only thing is patient is supine and you follow the same step. So now coming to the Courvoisier's law, for which I was talking about a lot in the initial part. So what this law state is that patient with jaundice, if there's a gallbladder, it's palpable. It's not due to stone. If a patient is having stone in his gallbladder, then his gallbladder won't be palpable. This you have to remember. Because what happens when stone is there, that will cause the fibrosis, means gallbladder will shrink. So gallbladder won't be palpable. In case of cholecystitis, the cartilage of eighth lip will also become tender when you palpate at the back. I already told you. This you can confirm in case of Boas sign when you look for it. And now coming to the exception of this law, this is very, very important. This examiners will always ask you what is Courvoisier's law, what are its exceptions. So because I already told in stone, gallbladder won't be palpable. But in this time, when there's a double impaction of the stone at the cystic duct and stone of the common bile duct, that time the gallbladder of the patient might be palpable. If there is a oriental cholangiohepatitis, there is pancreatic calculus obstructing the ampulla of Vater, there is mucocele due to the stone in the cystic duct. So all these four exceptions you have to remember. In that time, gallbladder might be palpable. To examine pancreas, like as we are covering pancreas here, so this is what I'll tell you here. There's something called mallet sign. While palpating pancreas is difficult. It's pancreas is not palpable normally, unless there is a growth or any cyst. What we do is we tell the patient to turn toward the right and flex his hip and knees. So and then you palpate the left subcostal epigastric region. Do a deep palpation. If there's a tenderness, then it's a sign of acute chronic pancreatitis. This is what we call it as mallet guy sign. If there is any mass of pancreas, you are able to palpate. If it is hard, if it is irregular, and if it is fixed, then think it's a pancreatic carcinoma. And in pancreatic carcinoma, this mass will be palpable only at the late stage. And this mass won't move with the respiration because it's retroperitoneal. It won't fall forward in the hyperextended position or in knee elbow position. On percussion, it will be resonant because when you percuss over the pancreas, there is stomach or intestine which are hollow in nature. So when you percuss, it will be resonant. If this mass is due to stomach, it won't be resonant because there's a growth in the stomach. If there's a stomach carcinoma, that will be dull. Then Definitely you have to do the percussion is the next one. On the solid organs, palpate for liver, palpate for spleen, palpate for any pelvic colon or thing. Auscultate. Auscultate for the bowel sound. Auscultate, where do you auscultate for the bowel sound is at the para-umbilical area along the umbilicus and supra-umbilical line for 2 to 3 minutes. When there is exaggerated sound, then think of some mechanical obstruction is there. When it is absent, think of paralytic ileus. Then do the rectal examination, which will, if there is any malignant deposit in the rectovesical pouch, it be this what that is called as Bloomer's shelf, or the pouch of Douglas. If there is any malignant deposit, it shows a metastasis has happened of the carcinoma. Look for other symptoms for your RS, any pleural effusion in case of lung metastasis. And definitely in the diagnosis, you have to draw the diagram of the liver and where is the stone you are suspecting. If you're thinking of stone or any carcinoma, if it is periampullary carcinoma, you have to draw the growth. The exam, people like it if in case, especially in your exam also. And even in the case seat of the patient, this is what you can do. This shows your dedication and a good clinicians. So you can say your diagnosis. For example, this is the patient with obstructive jaundice due to obstruction, probably at the CBD or else whatever is the site, hepatic duct or ampulla. And this obstruction is due to stone or carcinoma. Whatever is your finding, you can mention it like that. Generally, for the CBD stone, they might ask you what is the normal diameter of the CBD. So the normal diameter of the CBD is 7 mm. And there are three things which will give the predictor of CBD stone. If there is a jaundice, there will be increase of ALP when we do the investigation, and it will be dilated CBD in case of ultrasound. So all these three is there. You can definitely suspect stone at the CBD. And related to CBD, if it is having infection, cholangitis, CBD stone causing cholangitis, then you will have Charcot striate. I have already told you, just for the reminder. Pain will be there in Charcot striate due to the stretching of Glisson's capsule of the liver. It will have jaundice, it will have fever. And there's something called Raynaud's pentad. So all these symptoms of Charcot striate, plus there is a shock, which you will confirm by hypotension will be there, and there will be mental status of the patient will change. There will be kind of a delirium. So what happens is with the Charcot striate, if there is a septicemia due to E. coli or Klebsiella or S. faecalis, due to the cholangitis, there is a Charcot striate. If there is a septicemia, they will have a cholangitis with septicemia features, will call as Raynaud's pentad. 3 + 2, 5 symptoms. So Raynaud's pentad would be there. If your finding is GB carcinoma, then definitely they should have a feature of cancer, which is weight loss. There will be jaundice, and you might find hard, irregular mass at the right upper quadrant or at the GB side. They might ask you, how do you investigate? Basically, serum bilirubin, we have to look at. There will be increased direct bilirubin, which will confirm the finding of your obstructive jaundice. Do the liver function test. ALP, GGT will be increased, coagulation profile for the liver, and do the ultrasound. When we do ALP, it is more than 10 times, and GGT more than 40 times, well suggestive of any obstruction. Increased prothrombin time is there because of vitamin K dependent clotting factors, which are 2, 7, 9, 10, are decreased because vitamin K is not absorbed in the GI. So even if they have to remember, 7, 9, 10 are the clotting factors which are dependent on vitamin K. These factors are not absorbed from the GI because for the absorption of these, bile is needed. And when the bile is absent in the GI, these factors won't be absorbed, and vitamin K, they will be raised PTINR. Ultrasound is the most sensitive for your GB stone. Uh, as I already told, CBD stone will show you dilatation of the CBD duct, and there will be increased ALP. Then there are new other modalities, like they may ask you, when do you do MRCP or ERCP? So all these things they will ask you, when do you endoscopic ultrasound to differentiate between pancreatic cancer and chronic pancreatitis. ERCP is gold standard for the CBD stone removal and stenting of inoperable tumors. So, and there are new other modalities also that you have to see what all things are being done at your hospital. What is the protocol? Because this is a very common question. But okay, what do you do for this patient? What are the facilities available in your hospital for this? So just a promotion that I have already made question banks for medicine and surgery and other subjects also. You can go and check it out in the Kindle. It's only available on Kindle. I have not kept it on other websites or any in a printed form. Generally, people complain ki it's in mobile is difficult, but it's easy for you also, because most of the people now are reading on iPads or on the laptop. If you can download your Kindle app and the size becomes big, it becomes easy for you. For performer for obstructive jaundice, I'll be adding it in the description of this video. You can download it from there. Common viable questions are, they will definitely ask you whether, how do you manage this patient, what are the investigation treatment, GB stones, gallbladder stones, what is the etiology, types, complications. 5Fs, I already told you. CBD stones, etiology, risk factor, Mirzzi syndrome. This is very important for the Viva. It's an obstruction or stricture of common hepatic duct as a result of extrinsic compression of the gallstone in the Hartmann's pouch. So what is Hartmann's pouch? Hartmann's pouch is the posterior medial dilated part of the neck of the gallbladder, which is neck of the gallbladder is also called as infundibulum of the gallbladder. Majority of the stone occurs and stay at the neck of the gallbladder, which is posterior medial dilated part of the neck of the gallbladder, even in the neck. And what type of the stones do you find generally in the gallbladder? Most of the time, it is mixed type of stones, which has cholesterol, they have pigments, they have their epithelial debris and infective organism, which is around 80% of the time you'll find mixed type of gallbladder stone. 10% of the time you'll find cholesterol stones, and then will be a pigment stones. Then they might ask you callot triangle. Why it is important while doing laparoscopic cholecystectomy or open cholecystectomy? They want to locate cystic artery. Cystic artery will be here. Like you can see in the figure, they will ask you the boundary of callot triangle. So medially, it is by the common bile duct. Above, because it's the liver of inferior surface of the liver, and below is the cystic duct. So this will form your callot triangle, and here in between you will find the cystic artery. And if your diagnosis is related to periampullary carcinoma, pancreatic carcinoma, they will ask you about the management and surgeries. So coming to the important part, which is liver secondaries. Liver secondaries, patient will have history of dull aching, continuous pain at the right hypochondrium. There will be loss of weight, appetite, weakness, because they will have features of cancer has metastasized to liver. They will have jaundice, non-progressive and not associated with pruritus. If it is associated with pruritus, I already told, think of obstructive jaundice. So they will not have that. And in the examination, you might find pedal edema if it is, if the large liver is obstructing IVC, inferior vena cava. If there might be spine tenderness, if there is a metastasis from the breast, might go back to the spine. At the spine, there could be mets in males from the prostate, or wells from the bronchus, kidney, and other organs also. Mets can also go to the spine. In the perrectal examination, you might find any metastatic deposit in the pouch of Douglas. If you find polyps, then you can think of any colon-related malignancy. Pus and blood and pus could be due to any rectal or colonic malignancy. The patient with the liver secondaries will have dull aching type of pain. Pain is due to the stretching of Glissen's capsule. So this is also one of your exam viva question. So most of the time they will ask you, how do you assure like this is not a primary hepatoma or hepatocellular carcinoma, or it is a liver secondaries? So you have to remember, in case of liver secondaries, definitely you will find you might find the primary site, for which how to look for the primary site I'll tell you later. Most of the time with the liver secondaries, both lobe of the liver, right and the left part, will be affected. Liver will be nodular and there will be no tenderness. If tenderness is there, it's think of primary hepatoma, think of amoebic hepatitis. If there is irregular surface, and in both the thing, liver consistency will be hard. You have to remember that. Only one lobe is affected, irregular surface. Think of primary hepatoma or hepatocellular carcinoma, which is generally less common, and liver secondaries are more common. Edge would be round in case of hepatocellular carcinoma. Ascites will not be there. Ascites is more common in liver secondaries. They might ask you from where this liver secondaries come, what all organ. Then you have to say, answer GI, colon, stomach. Then from the breast in females, prostate in males, then lung carcinoma, pancreas, carcinoma, ovarian carcinomas in female, testicular carcinoma in males. If they ask you what causes large metastasis of the liver, this is due to melanomas, carcinoma of anal canal, or choriocarcinoma. This liver mets is through hematogenous route, through portal vein and hepatic artery. It is could be due to your lymphatic spread. Both I already told it would be hard inconsistency. Good prognosis is there in case of colon carcinoma, in case of the carcinoid tumors. Good prognosis there. Most common liver malignancy is your liver secondaries. Most common liver malignancy is secondary. Most common liver benign, if there is a benign, then it could be due to hemangioma. When we look at the primary hepatoma, it will be more common in males than female. Common age group would be more than 50 years. Person might have history of alcohol. Well, they would be alcoholics. And the risk factors history might be also there, like they might have hepatitis B or C, chronic hepatitis. When there is a cirrhosis, then only you will find ascites or jaundice. Otherwise, in primary, you may not find jaundice. So this, if you find there is a liver secondary, then you look for the primary site. Most common primary site could be stomach. Then there might be history of vomiting with or without blood. Look for anemia and epigastric mass. Pancreas, I already told, head and tail or body. Severe back pain, epigastric pain radiating toward the back. Patient will have other symptoms of pancreatic carcinoma or even pancreatic mass you can find in the late stage. Periampullary carcinoma, patient will have obstructive jaundice with the pruritus. There might be a palpable gallbladder or a mass at the epigastric region. Colorectal carcinoma, the person will have history of constipation, bleeding per rectum. In the breast carcinoma of breast, in the female, you might find any breast lump or discharge. Malignant melanoma, patient will have history of wide excision of moles or any amputation. In the examination, you may confirm that. If there is seminoma of undescended testis, like there is only one testis in the scrotal pouch, then you can think of it could be a seminoma of undescended testis. When primary is not found, like for example in your clinical examination, then we call it as occult primary. And then you have to think of carcinoma of cecum, pancreatic carcinoma, this is are the common reasons for occult. When primary are not found after the investigations, like you have, let me change the pen. If you're not, even after doing the investigation, like common investigation, ultrasound, x-rays, you're not able to find out, then think of that what we call as unknown primary. Occult is based on examining clinical examination. You are not able to think of pancreatic carcinoma and cecal carcinoma. If unknown primary, even after investigation is not found, we call it mostly as primary, unknown primary, and unknown primary. And the reason could be bronchogenic or anything related to the lung. It could be carcinoma of the prostate. It could be malignant melanoma choroid. These three things you have to keep in mind when there's unknown primary after investigations. So there are conditions where primary will occur before the secondary, where the liver secondaries occur. So those are the carcinoid tumors or rectal cancers, where both occur at the same time. Primary and secondary are coming concurrently or simultaneously. Then you can think of carcinoma of stomach, where secondary occur before the primary. Like liver mets has come, but you are not able to find primary. Then you can think of malignant melanoma of choroid, which comes very late. So Viva questions would be, how will you manage this patient, primary site and investigations, hepatocellular carcinoma, when do you do liver transplant, what are the treatment modality, what are the surgery, what are the scoring, like child pug scores, and there are a lot of other scores. So all those things you have to read and remember for your exam. And for more videos, and subscribe to my channel, Ankit Chandra. I'm available on Facebook, Instagram, Twitter. And also, if you have any doubt, comment it in the comment section of this video. I'll try to answer. And next week, I think I'll be putting up video on gastric carcinoma or a stomach case. And after that, I think on right iliac So stay tuned. See you guys in the next video. Tata, bye bye, and all the best.